So as Jim was saying, when he had this epiphany about this new product, he came to me because the actual solution is surgical. You have to be able to implant something, because if you try to make these custom abutments on round implants, just as he said, it creates a cantilever and it doesn't work. So the answer was, he said, can we put it in the bone? And indeed, he's right. As a maxillofacial surgeon in the United States, we don't restore. When we go on, we don't do everything anymore. We specialize in that area. And part of that specialization is doing trauma. We do a lot of facial trauma, facial reconstruction. And the things that we use in it are these titanium plates to reconstruct the mandible if we have to do a resection. And what he showed me was something that looked just like a link from that plates that we use, mini plates and others. Now, I've tried to take out a couple of those things. I've talked to some of my colleagues who's tried to take them out, and they integrated. Bone grew over them, and it's almost impossible. You have to cut them out. So when he brought this to me, I was like, yeah, this makes a lot of sense. We should be able to do this. We should be able to take this platform and actually place it in trabecular bone. If it's made of titanium, as we talked, the alloy, our titanium alloy, it should integrate. And so we did a little study. So here's what we did. We developed this, our little platform, and you can see it here. And what we did was we took the OsteoSpeed Astrotech implant, because it had a nice angle to it that would fit through a hole in a platform. And then if you look closely here, you'll see these screws. As a surgeon, when you do these fixation plates, we put in mini screws. You put them in to hold the plate across the fracture. And so it made sense to me we should have something to fixate this platform until we get the implant through it. And then theoretically, these little screws would have been obsolete. And this is what we did. And then we put a small, you can see that round, we just took the off the market flat cover screw, put it on top of the implant. And this is what we were left with. And this is what it would look like after we finished the surgery. So you can see, here's our little retention screws, here's our implant going through, the AstroSpeed, and the flat cover abutment. When we opened them up after 3 months, if you look closely here, you see this? It's bone. It's all integrated. You can even see here it covered the screw. So we knew, based on this, that it integrates. Bone grows over the top of this. It's very friendly. But because we only had this small little cover screw, we had to remove the bone in order to get to the access to restore it, which we did. And then we made custom abutments, and then we restored the tooth. So we eliminated a lot of this embrasure space by coming from the bone and coming up. And this is what it would look like clinically restored. Now, what Jim was talking about before, we did 10 implants, 8 patients, and we followed them along. And this was our prototype. And what we learned from that is, and to date, I've taken out 4, but after 2 years, they lasted and functioned for 2 years. We have the rest of them, the 6 that are still in, are still functioning. And it was a complete prototype. But what we found was, because we used the retention screws, because we had the OsteoSpeed that has our threads going all the way to the top, we had micro leakage. And over time, we couldn't seal that off. So what we have now is an industry standard seal between our platform and the implant, and we have all of the industry surface treatments on the platform and the implant as well. And I know that Duncan will kind of go over some of the studies that we've done on this, so we feel like we've really solved that problem of any micro leakage.
Well, let me just interrupt you. The problem that I faced was I had to reverse engineer everything. And
Right.
now, because I'm just a dentist, and so I would go to the medical machining companies and gave them the idea, and their engineers said, well, we need an implant. Well, it wasn't a good implant to use, and we had to do everything backwards. So now we aren't doing it like that. We are having our own company, which Duncan and Brad will go over.
Yeah, and the whole, you know, we've manufactured this product. So we know that there's adequate seal between the platform and the implant. But this is just an example of, this is a Zimmer implant, and this is our platform in place that we did, and you can see the difference. Here's this large overhang on the model. Here's the beta version of our platform. So this is what we were talking about. The 10 completed cases, the 8 patients, 2 patients had 2 implants. We did it from May 2009 to December 2009. We did have excellent bone integration on everybody. Initially, we had eliminated all of the food trapping. We had great contacts. Everything lasted, like we said, for up to 2 years. And then we eventually started seeing some bone loss. And like I said, we had to take out 4. And Jim had alluded to it before. The patients that we selected were friends or family that we could trust, because in the United States, it's very litigious and you have to be very careful when you bring new products on. And our primary criteria was we didn't want to be sued. So some of these patients weren't ideal when we were placing these, but we got a very respectable result. And I think that that's what let us move on to start the company and consider more of this industry standard. But this is what we found from it. We had talked about it. You know, we used the OsseoSpeed. It had that poor fit because you can see that it has threads all the way to the top, which actually makes a micro gap all the way to the top. The capture screw, we used their typical capture screw, and I think you had one come loose or something. Two came loose, the screw loosened. Yeah, so it loosened, and we know that that contributed. Obviously, if the screw's loose, then you don't have good contact. The zirconium abutments, we had them made to that platform that we had machined, and we felt like that it wasn't a perfect seal. You know, the material, surface treatment, sterilization quality was things that Jim and I had basically done in his lab. And so we weren't using the industry standard, which we have now in the new product. So this is the bottom line. We've used that beta experience, and we've learned how to re-engineer this product and make it the most efficient that it can be.